Very good evening, everybody. So if you could share my voice and see the screen properly, type yes on the chat box. If you could share my voice and see the screen properly, type yes on the chat box. Want whomsoever present to acknowledge faster that if you could share my voice and see the screen properly, type yes on the chat box. Okay. So today we are going to talk about the pharmacology people. We have been on a break yesterday. And today we are going to talk about the pharmacology. Speaking of a pharmacology, prior moving on to the pharmacology, I want to know that I want you to make sure that you have understood all the previous things clearly. Okay, we have done so far anat, physio, biochem, patho, micro, and anesthesia and dermatology. Nearly 8 subjects were completed already in the first session. So this is a session 2 where we are going to read about your pharmacology, PSM, medicine, and surgery. Okay, what are the subjects we're going to cover here? Pharmacology, medicine, PSM, and your surgery. And in the third division, we do the clinical along with the obstetric and gynecology. So this is all about the today's one. So today's session, we're going to talk about your, what do we call it? We're going to talk about your pharmacology. So speaking about the pharmacology, so prior moving on to the topic, I want whomsoever present to acknowledge faster. If you could hear my voice and see the screen properly, type yes on the chat box. If you could hear my voice and see the screen properly, type yes on the chat box. Okay, moving on to now. So pharmacology, speaking about the pharmacology would be divided into general pharm and the systemic pharmacology people. Pharmacology will be divided into general pharm and the systemic pharmacology. And speaking about the high yield pharmacology, systemic pharmacology. Speaking about the high yield portion of your pharmacology, we are having a variety of things. So the high yield area of your pharmacology includes what are the areas that you need to cover faster. So speaking about the high yield area, the very first area is going to be your ANS, CNS, CVS, endocrine, and antimicrobial. Okay, and the antimicrobial are the areas where you may cover or you may expect 80% of the question. Remaining 20% may come from orthocoids, respiratory, GIT, and your miscellaneous topics like anti-cancer, immunosuppressants, tumor, TNF alpha, targeted therapies, those areas where you may expect to see the 20% of your questions. Okay, so if we cover this portion, we may get up to 8 to 9 questions on your pharmacology. If you have covered this questions perfectly, then you may get up to 8 to 9 questions in pharmacology. So we are going to talk about your pharmacology session. And the first one is your general pharmacology people. And the first one is your general pharmacology. Speaking about the general pharmacology, your general pharmacology is divided into pharmacokinetics and pharmacodynamics people. Pharmacokinetics and pharmacodynamics. What is a pharmacokinetics? What drug does to body is your pharmacokinetics. Sorry, pharmacodynamics. And what body does to drug is your pharmacokinetics. Okay. What drug does to your body is your pharmacodynamics. And what body does to drug is your pharmacokinetics. That means what sort of how your body is reacting whenever the drug is coming in, how does the body is taking it, absorbing it, metabolizing it, and eliminating it. This will be discussed in your pharmacokinetics, while what sort of drugs are available and what sort of receptors are available in your body, how does that drug is producing intrinsic activity in your body, That will be discussed in your pharmacodynamics. So speaking about that, we are going to talk about the highlights of your general pharmacology. So speaking about the general pharmacology, first area of interest is your route of administration. First area of interest is your route of administration. Speaking about the route of administration, we are having an enteral route, and we are having a parenteral route, and we are having a like a multiple route of administration. But what we are going to discuss here is only the highlights, people. What we are going to discuss here is only the highlight. So the first highlight in the route of administration is the very straight MCQ that IV has a bioavailability of 100%. Very important. IV has a bioavailability of 100%. And what are the sublingual route of drug administrated? What are the drugs which can be administered through the sublingual route? One is your nitroglycerin, isosorbate dinitrate, clonidine, and nifedipine. Okay, the very important example are your nitroglycerin, ISDN, clonidine, and nifedipine. Okay, then oral route is avoided if the drug has a high first pass metabolism, people. If the drug has a high first pass metabolism. So what is mean by first pass metabolism? A part of a drug which is metabolized in your body, prior and metabolized into your liver, especially prior entering into systemic circulation. A part of the drug which is metabolized in your liver prior entering into the systemic circulation is so called as first pass metabolism. So any drug which has a high first pass metabolism, then you have to prefer the IVR, IMR subcutaneous route or parenteral route, or maybe the sublingual route. For example, insulin is one of the classical example that this drug has a high first pass metabolism. Your insulin is metabolized by your liver. Yes or no? Now, speaking about that, the liver, what is the major route of administration of your drug? The major route of administration of your insulin is mostly the subcutaneous injections. Yes or no? Mostly the subcutaneous injection. Why? Because insulin have a high first pass metabolism. So whatever the drug which is having a high first pass metabolism, then oral route should be avoided and parenteral route should be preferred. Okay, so these are the highlights in the case of your route of administration. You have to remember. What are they? First one, straight point. IV has a bioavailability of 100%. And sublingual drugs are, examples of the sublingual drugs are nitroglycerin, ISDN, that is isosorbate dinitrate, clonidine, nifedipine, and so on. And oral route is avoided if the drug has what, people? If the drug has a high first pass metabolism. Oral route should be avoided if the drug has a high first pass metabolism. Then you are having absorption. So speaking of absorption, whenever the pH is equal to pKa, then the drug is 50% ionized and 50% non-ionized. So whatever the general pharmacology we are talking about here is just the highlights. Okay, what are the facts you need to remember? Because very rarely they ask a question from the general pharmacology, and that too will be related to the more or less like examples of such some things. Okay, that's why I am quoting only the highlights of your general pharmacology. So speaking about that absorption. So what is the absorption? So how does the drug is getting absorbed in your body with the intestine, especially? So what are the modes of absorption? So general physiology, we have discussed the modes of absorption like passive diffusion, facilitated diffusion, active transport, which is a primary and a secondary, exocytosis and endocytosis are the modes of your absorption or mechanism of your absorption that we discussed in our physiology section. If you have a thing, you can able to look at your physiology section and you can cover it up. So what are the factors that can influence your absorption? So whenever the pH is equal to pKa, then the drug is 50% ionized and 50% non-ionized. 50% ionized and 50% non-ionized. Then you have a bioavailability. What is a bioavailability? The amount of drug which is available in systemic circulation, is so called as bioavailability, or the percentage of drug. I rather say the percentage of the drug rather than the amount. I used to quote a percentage because that gives the highest value, or most preferable word we can use is the percentage of the drug which is available in the systemic circulation after first pass metabolism. If I want to quote the first pass metabolism here, after first pass metabolism, the percentage of the drug which is available in the systemic circulation is bioavailability, where bioavailability is denoted by the letter F, where F is equal to area under curve of oral by IV into 100% is the formula for bioavailability. So what is the formula? F is equal to area under curve of oral divided by area under curve of IV into 100% is your bioavailability formula. And what is bioavailability? The percentage of the drug which is available in the systemic circulation after the first pass metabolism is so called as bioavailability. Then we are having a first pass metabolism, people. So what is the first pass metabolism? So the first pass metabolism is the amount of drug which is available in the systemic circulation for action after the first pass metabolism. After the normal absorption, the drug goes to the liver through the portal circulation, and what sort of amount of drug will be metabolized in the liver. That amount of drug which is metabolized in the liver is so called as first pass metabolism. So what are the drugs with the high first pass metabolism? Another very important example based question. What are the drugs with the high first pass metabolism? Another important question with the example type of questions. So I used to remember with the mnemonic of Nancy likes her pre-med school. Nancy likes her pre-med school. Nancy likes her pre-med school is the example of your drugs with the high first pass metabolism. So N stands for nitrates. N stands for nitrates. L stands for lignocaine. H stands for hydrocortisone. P stands for propanolol. M stands for morphine. And S stands for salbutamol. So what are the things you have to remember, people? What are the drugs with a high first pass metabolism? What are the drugs with high first pass metabolism? Which is your Nancy likes her pre-med school is the mnemonic. Well, N stands for nitrate. L stands for lignocaine. H stands for hydrocortisone. P stands for propanolol. M stands for morphine. And S stands for salbutamol. Okay. So what is the first pass metabolism, people? What is the first pass metabolism? The amount of drug which is metabolized in the liver prior entering into the systemic circulation is so called as first pass metabolism. Okay, what is the letter we use for the bioavailability? What is the letter we use to indicate for the bioavailability? What is the letter we use to indicate for the bioavailability? F is the letter we use to indicate for the bioavailability, people. F is the letter we use to indicate for the bioavailability. Then you have a distribution. So speaking about the distribution, after the absorption, the drugs enter into the systemic circulation, and then it gets distributed all over your body. Okay, and then it gets distributed all over your body. Speaking about the distribution, what are the important things you have to remember in case of distribution is 2 points you have to remember, people. One is your lipid soluble drugs have a high volume of distribution. Lipid soluble drugs is having a high volume of distribution. And another one is highly protein bound drug which is having a least volume of distribution. Highly protein drug is the one which have a least volume of distribution. Okay, are the important things you have to remember. So what are they? One is a lipid soluble drugs, or the one which has a high volume of distribution. Another one is a highly protein bound drug which has a low volume of distribution, Then volume of distribution is equal to dose by concentration, people. What is the volume of distribution? Formula, dose by concentration. Okay, very important one. Okay, so apart from that, there are drugs which can be metabolized through the dialysis. What are the dialysis? What are the drugs where we do not, where the dialysis will not work? Okay, what are the drugs where dialysis will not work? Okay, I used to remember with the mnemonic of dialysis, I don't care. Dialysis, I don't care. D stands for digitalis, and I stands for imipramine, and another D stands for diazepam, and O stands for opioids, and organic phosphate, and then amphetamine. O stands for opioids, organic phosphate, and amphetamine. So these are the drugs where the dialysis will not work, people. These are the drugs where the dialysis will not work. Okay, amphetamine, opioids, organic phosphate, imipramine, digitalis, and diazepam. Imipramine, digitalis, and diazepam. Okay, some books have a mnemonic of avoid dialysis. So you, however you remember, you can remember that. Okay, then you have a metabolism. So speaking about the metabolism could be of two types. Either it is a cytochrome P450 dependent one or cytochrome P450 independent one. Cytochrome P450 dependent or cytochrome P450 independent one. Speaking about the cytochrome P450 dependent one, what are the things you need to know is most common cytochrome P450 enzyme is 3A4. Most common cytochrome P450 enzyme is 3A4, and the second most common is your 2D6, and the second most common is your 2D6. And then you have a phase 1 reaction where you use as a oxidation, reduction, and a hydrolysis. Oxidation, reduction, and a hydrolysis. Apart from that, phase 2 reaction involves conjugation, acetylation, methylation, and sulfation. Conjugation, acetylation, methylation, and sulfation are the phase 2 reactions, people. Are the phase 2 reactions. Okay, then you have excretion, clearance formula. So what is the clearance? Clearance is 0.695 into VD by T off. 0.698 into VD by T half. Or some book says like 0.7 into VD by T half. They rounded it up. One time in FMGE, they asked this as a question, people. Calc, what is the formula of T half they had mentioned? And on the option they had mentioned, they had given it as 0.7 into VD by CL was the answer given there. So both are same, right? As per the multiplication, T half goes here and the CL goes here. It will give a right answer, right? One time they asked this as FMG. What is the correct formula for half-life of a drug? What is the correct formula for half-life of the drug? Was the mnemonic which was been given here. And what was that? What was the half-life of the drug? Formula 0.7 into VD by T half. 0.7 into VD by T half. Okay. Now, speaking about that, sorry, VD by clearance. 0.695 into VD by clearance was the T half formula. Okay, then you have a first order and second order, zero order kinetics. So speaking about the first order kinetics, constant fraction of drug is eliminated per unit time. Constant fraction of drug is eliminated per unit time is first order kinetics, while constant amount of drug is eliminated per unit time is zero order kinetics. Constant amount of drug is eliminated per unit time is zero. Constant fraction of drug is eliminated per unit time is zero. Your first order kinetics. Most of the drugs will follow what order kinetics, people? First order kinetics. Most of the drugs will follow what order kinetics? First order kinetics, while only a few will follow the zero order kinetics. So what is the zero order kinetic drug? So I used to remember with the mnemonic of Ansi wants Alan and Tanya to party. Ansi wants Alan and Tanya to party. Okay, Ansi wants Alan and Tanya to party was the mnemonic I uses. A stands for alcohol, W stands for warfarin, A stands for aspirin, T stands for theophylline, Another T stands for tolbutamide, and P stands for phenytoin. Another P stands for phenytoin. Alcohol, warfarin, aspirin, theophylline, tolbutamide, and phenytoin are the drugs which follows the zero order kinetics. Okay, what is a zero order kinetics? Constant amount of drug eliminated per unit time. What is a first order kinetics? Constant fraction of drug eliminated per unit time. So first order kinetics is kind of like a linear kinetics, people. Okay, for example, like how do I say it is a linear kinetic? For example, I say consider 100 mg of drug A has been given. 100 mg of drug A has been given to a patient. 100 mg of drug A has been given to the patient, and then you have this, T half of 1 hour. Consider T half is equal to 1 hour. At the first half, how much amount of, at the end of your first T half, how much amount of drug will be present in the circulation, people? How much amount of drug will be present in the circulation at the end of the first T half? T half is 1 hour. After 1 hour, how much amount of drug will be there? Only 50 mg. Yes or no? Only 50 mg will be there. And the second T half, how much will be there? And the second T half, how much will be there? After 2 hours, how much amount of drug will be there? How much amount of drug will be there after 2 hours? How much amount of drug will be there after 2 hours? 25 mg. Am I right? And 3 hours, it is 12.5 mg. If you are looking at the blood concentration, at the first 1 hour, 50 mg of drug has been eliminated, and the second hour, 25 mg has been eliminated. Is that a constant amount of drug is eliminating? No. 50% of the drug concentration is eliminating. So, constant fraction of drug eliminated per unit time is so called as your first order kinetics. Well, constant amount of drug eliminated per unit time is so called as zero order kinetics, people. Okay, constant amount of drug eliminated per unit time is zero order kinetics. For example, same 100 mg of drug A has been taken. Consider like same 100 mg of drug A has been taken. So that 100 mg of drug A has been taken, and after 1 hour, you see there is a 90 mg. Consider 100 mg of drug A has been taken. After 1 hour, you may see there is a 90 mg. And after 2 hours, you may see 80 mg. And after 3 hours, you may see 70 mg. That means you see there is a difference in the concentration, but the drug eliminated is 10 mg per hour. Okay, 10 mg per hour. This is zero order kinetics, where constant amount of drug eliminated per unit time is so called as your zero order kinetics, while constant fraction of drug eliminated per unit time is so called as first order kinetics, while constant fraction of drug eliminated per unit time is so called as first order kinetics. So this is all about the things you have to know in terms of your pharmacokinetics, people. So we have done our pharmacokinetics here. So what are the things you have to remember here in the case of your pharmacokinetics? What are the things you have to remember? One is your bioavailability of IV is 100%. When pH is equal to pKa, then the drug is 50% ionized and 50% non-ionized. And then what is the letter we use to denote the bioavailability? F. What is the drug which we use to denote the bioavailability? F. What is the first pass metabolism? The amount of drug which is metabolized in the liver before entering into the circulation is so called as first pass metabolism. What are the drugs with a high first pass metabolism? What are the drugs which is a high first pass metabolism? Nancy likes or pre-med school. What are they? Nitrates, lignocaine, hydrocortisone, propranolol, morphine, and salbutamol. Okay, then distribution. Lipid soluble drugs have a high VD. High protein bound drugs have a low VD. What is the formula of VD? Dose by concentration. Okay, what are the drugs where the dialysis will not work? Amphetamine, opioids, organic phosphate, imipramine, digitalis, and diazepam. Digitalis and diazepam. Metabolism, most common cytochrome P450 enzyme is 3A4. Second most common is 2D6. And excretion 0.695, clearance formula 0.695 into VD by T half. And what is a first order kinetic? Constant fraction of drug eliminated per unit time is first order constant. Amount of drug eliminated per unit time is zero order. What are the drugs which follows the zero order kinetics? Nancy wants Alan and Tanya to party. So what are they? Alcohol, warfarin, aspirin, theophylline, tolbutamide, and phenytoin. Okay, tolbutamide and phenytoin was the drugs which follows the zero order kinetics. So clear about that? Shall I move on to the pharmacodynamics of your general pharmacology? Shall we move on to the pharmacodynamics of your general pharmacology? Okay, speaking about that, what is the pharmacodynamics, people? What drug does to body is so called as pharmacodynamics. What drug does to body is so called as pharmacodynamics, where the drug binds with the receptor and leads to the formation of drug receptor complex, and you see there is a desired effect production. Okay, whenever the drug binds with the receptor and there is a formation of your drug receptor complex, and then there is a production of your desired effect. So speaking about the drug, we are having two types of drug. One is your agonist drug, another one is your antagonist drug. Another one is your antagonist drug. So what is the agonist drug? The drug binds with the receptor and activates the receptor. And what is the antagonist drug? The drug binds with the receptor and makes the receptor unavailable for agonist. Or antagonist drug. Okay. So what is the agonist drug? The drug binds with the receptor and activates it, while the antagonist one, or the drug binds with the receptor and makes the receptor unavailable for agonist. Then we are having a types. What are the types? One is your full agonist, where drugs binds with the 10 receptor and activates all 10 of them, are so called as full agonist, where the intrinsic activity value is 1. That means the drug binds with the 10 receptor and it activates all the 10 receptors, so called as full agonist. And then you have the partial agonist. What is meant by partial agonist? The drug binds with the 10 receptor and activates only a few of them. Okay, the drugs binds with all the receptor but activates only few of them, as so called as partial agonist. Okay, and among that I want you to write a note here. Write it as a note. A partial agonist can sometimes be an antagonist. Partial agonist can sometimes be an antagonist to full agonist. You can't understand this, right? Yes or no? Partial agonist can sometimes be an antagonist to your full agonist. Write it as a note next to the partial agonist, because why I wanted to insist you is, for example, we are giving the 20 mg of drug is required to occupy 10 receptor. Consider, okay, occupy 10 receptor. Among that, we give a 10 mg of full agonist and a 10 mg of partial agonist to the activate this 10 receptor. Okay, what happens? This 10 mg go and binds with 5 receptors, and this 10 mg goes and binds with 5 receptors. Yes or no? So both of them will go and binds with their respective 5 receptors. Okay, but in this scenario, if you give a 20 mg of full agonist, all 10 will be activated. All 10 receptors will be activated. But here, if you give 10 mg of agonist and 10 mg of partial agonist, 5 receptors of full agonist will be activated and only 3 of the partial agonist will be activated. Okay, a few receptors will be occupied but remains unactivated. Okay, few receptors will be occupied and remains unactivated or inactivated. So the intrinsic activity for here is 1, but it is 0 to somewhere x to somewhere 1, somewhere between 0 to 1. So this is the intrinsic activity of whenever you mix a partial and a full agonist, this will be your net intrinsic activity value. Then you have an inverse agonist. Speaking about the inverse agonist, so inverse agonist, sometimes the drug binds with the activated receptor and inactivates them. Okay, whenever sometimes the receptor will think like the drug has been bound to them and activates them automatically. So what is the inverse agonist? The drug binds with the activated receptor and inactivates them, as so called as inverse agonist. That is, the intrinsic activity value is -1. Intrinsic activity value is -1 in this scenario, people, for the inverse agonist. Okay, -1, and there will be the scenario for the inverse agonist. Then for antagonist, we are having a types of antagonist: physical antagonist, chemical antagonist, physiological and pharmacological. Physiological and pharmacological antagonism we are having for the types of your antagonism. Then speaking about that, we have talked about the drugs, which is agonist and antagonist drugs. And now we are going to talk about the receptors. So if you finish the drugs and receptor, that means 80% of your pharmacodynamics is over. So what are the receptor? So the first one is your ion channel receptor. We are having 4 classes of receptor: ion channel receptor, G protein couple receptor, enzyme linked receptor, and intracellular receptor. Okay, what are the 4 types of receptors we are having? Ion channel receptor, G protein couple receptor, enzyme linked receptor, and intracellular receptor. So what are your ion channel receptor? We already discussed that in the nerve muscle physiology section. Yes or no? Drug binds with the receptor. Okay, drug binds with the receptor and activates it. And once it activated, the receptor opens certain channels. And this opening of the channel is totally depend upon the what type of receptor has been bound. If it is an excitatory or inhibitory. If it is an excitatory, then sodium influx will happen. If it is an inhibitory, then chloride influx will happen. Okay, then chloride influx will happen. This is so called as voltage gated ion channel receptor. Ion channel receptor. And then you are having a G protein couple receptor. So speaking about the G protein couple receptor, we are having a GS, GI, and GQ type of receptors. What are they? GS, GI, and GQ type. Among the GS will activate adenylyl cyclase and increases cyclic AMP concentration and production of intrinsic activity, while GA inhibits adenylyl cyclase and suppresses your cyclic AMP activity and thereby production of intrinsic activity. Then you have a GQ receptor which activates phospholipase C and thereby activating DAG or phosphatidyl inositol phosphate 2 and converts them into IP3 and then produces intracellular calcium. Increase in intracellular calcium. Okay, increase in intracellular calcium and thereby production of your intrinsic activity. So GS and GA acting on adenylyl cyclase, while GQ activates phospholipase C, where PIP2 will be converted into IP3 or DAG, and then it will be converted into and then it will cause us a intracellular calcium level to rise. Whenever there is a more intracellular calcium, intrinsic activity will be produced. Then you have an enzyme linked receptor. Receptor has been linked with the enzyme. Whenever drugs binds with them, activation of that particular enzyme will happen. Then you have an intracellular receptor, which is a cytoplasmic and nuclear receptor. Cytoplasmic receptors are the classical examples of vitamin D and corticoids, while nuclear one are vitamin A, thyroid hormone, steroid hormone, and PPAR receptors. So these are the 4 classes of receptor, people. What are they? Voltage gated ion channel, G protein couple receptor, enzyme linked receptor, intracellular receptor. Ion channel receptor, drug binds with the receptor, receptor opens certain ion channels, thereby causing a potential change. Okay, and G protein couple receptor, GS, GA, and GQ. GS and GA act on adenylyl cyclase, while GQ will act on phospholipase C. Okay, then act on converting the PIP2 to DAG and IP3, and then thereby raising the intracellular calcium level. Then you have an enzyme-linked receptor, and then you have an intracellular receptor. Intracellular is further classified into cytoplasmic and nuclear receptor. Okay, cytoplasmic and nuclear receptor. So this is all about your receptors and drug, people. Then apart from that, you need to know about dose response curve, where therapeutic index, the formula is TD50 by ED50, which measures the safety of the drug. Very, 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 very important MCQ in terms of formula. Okay, therapeutic index measures the safety of the drug, and the formula of therapeutic index is also very, very important. TD50 by ED50 or LD50 by ED50 is the formula. Then efficacy, maximum effect, potency, maximum effect with the minimal dose. Okay, potency, maximum effect with the minimal dose, while the efficacy, which is a maximum effect. Okay, so efficacy, the classical measurement of efficacy is your Emax, while potency, it is your ED50. Okay, potency, the parameter is ED50. Emax belongs to efficacy, while TD50 by ED50 belongs to therapeutic index, which marks the safety. Okay, which marks the safety. Then you have phases of clinical trials. One is your clinical pharmacology phase, and apart from the clinical investigation phase, third one is clinical trial, and fourth one is post-marketing surveillance. Very, very important is your phase 4, where you see the post-marketing surveillance of the thing. Okay, where you see the post-marketing surveillance is your phase 4 of clinical trial, while healthy volunteers are used on phase 1 of your clinical trial. Very, 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 very important. Okay, phase 1 of clinical trial, we are having a healthy volunteers, and the post-marketing surveillance is seen in phase 4. With this, we have completed your general pharmacology, people. With this, we have completed your general pharmacology. So I compiled it in a single page of your general pharmacology so that you can able to understand most of the questions. You can able to understand most of the questions, and you can answer out most of them too. Okay, so shall we move on to the next area of interest? Okay, speaking about the next area of interest, our next area of interest is your ANS, people. Okay, our next area of interest is your ANS. Speaking about the ANS, so what is the main function of your, what are the divisions of your ANS? Very, very important. What are the divisions of your ANS? Speaking about the ANS divisions, we can divide the ANS into 3 types. Namely sympathetic, parasympathetic, and enteric. So speaking about the enteric nervous system, where you see the Meissner's and myenteric nerve plexus, and myenteric nerve plexus, which forms your enteric nervous system, and sympathetic nervous system is responsible for your flight or fight response. While parasympathetic nervous system will be responsible for your break to your sympathetic nervous system. So whatever sympathetic nervous system does, It does exactly opposite. What does your sympathetic nervous system does? It does exactly opposite. Now speaking about that, sympathetic and parasympathetic nervous system people. So what we are going to talk about is, as I said in the class, you have to remember one sentence for your entire lifetime. Okay, what are the things you have to remember for your entire lifetime is, number one is parasympathetic nervous system will stimulate all except heart, all organs except heart. Okay, parasympathetic nervous system will stimulate all organs except heart. So speaking about that, in the heart, it can produce a brady and a pupil, constriction or dilation, constriction of your pupil and bronchus, So GI motility increases or decreases? GI motility. I said parasympathetic will stimulate all except heart. So heart, it can decrease the heart rate. So what about the GI motility? It increases or decreases? It increases. What about the urinary secretion? It increases or decreases? It increases. What about the salivary gland secretion? Salivary gland secretion. It increases or decreases? Increases. You have to remember this line till the end of your life. And remember always, whatever the things you have to remember with the vitamin K dependent clotting factor, I used to remember along with that cranial nerve innervation of your parasympathetic nervous system. Okay, what are the cranial nerves which innervates your parasympathetic nervous system? Which is 3, 7, 9, 10. While vitamin K dependent clotting factors are 2, 7, 9, 10. Yes or no? We studied in the vitamin K of your biochemistry section that we studied that the things we need to know about the vitamin K are K1, K2, K3. And we also studied two important points. One is your gamma carboxylation of glutamic acid, and another one is your vitamin K dependent clotting factors are 2, 7, 9, 10, protein C and protein S. Yes or no? Protein C and protein S. Okay, fine. Then you have a sympathetic nervous system where you see the flight or fight response, and it works exactly opposite. So you can able to do that. Pupillary constriction or dilation, bronchoconstriction or dilation. So this is the parasympathetic nervous system, people. So remember, sympathetic nervous system post-ganglionic neurons will carry adrenaline or noradrenaline as a neurotransmitter. Adrenaline or noradrenaline as a neurotransmitter, while parasympathetic postganglionic carries acetylcholine as a neurotransmitter. Okay, acetylcholine as a neurotransmitter. Whatever carries acetylcholine or cholinergic neuron, while whatever carry adrenaline or adrenergic neuron, or your adrenergic neuron. So speaking about the cholinergic and adrenergic neuron, whatever the drugs which can stimulate the cholinergic system are your cholinergic agonist, which is technically stimulating your parasympathetic. Whatever antagonist which can activate, it can activate the sympathetic nervous system and suppresses your parasympathetic nervous system. And similarly, adrenergic agonist will stimulate sympathetic nervous system and suppresses parasympathetic, while adrenergic antagonist technically stimulates parasympathetic and suppresses sympathetic nervous system. You have to remember these things as a basic principle prior moving on to the ANS, people. Prior moving on to the ANS. So clear about that? Clear about that? Shall I move on to the next area of interest? So first area you are going to do is your cholinergic drugs, people. Cholinergic drugs. What are the drugs which act on the cholinergic neuron? What are the drugs which is acting on the cholinergic neuron? So don't be confused with the lot of like a circuit board. So remember it like as choline from outside. So follow here, people. Very, 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 very important. Follow here. Once we finish the cholinergic and adrenergic, I give you a break. But follow here. Very, 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 very important. Okay. So because if you miss it, you cannot identify where is connecting where. Okay, you have to remember it and follow the highlights. Okay, first highlighted thing here is a choline. So choline from outside is transported inside via the transporter which takes sodium along with it. Via the transporter which takes sodium along with it. And this transporter is inhibited by the drug called as mityrosine. This transporter is inhibited by the drug called as mityrosine. And the entered choline will combine with acetyl-CoA and converts into acetylcholine mediated by choline acetyl transferase enzyme, which is considered to be the rate limiting enzyme of your acetylcholine synthesis, which is considered to be the rate limiting enzyme of your acetylcholine synthesis. Now, the formed acetylcholine will be incorporated into synaptic vesicle. Now the formed acetylcholine will be incorporated into synaptic vesicle. Incorporation is inhibited by besamicol. Incorporation is inhibited by besamicol, and the acetylcholine will be released into the into the synapse whenever the action potential comes. So whenever the action potential comes, the acetylcholine will be releasing into the synapse. So whenever the acetylcholine released into the synapse, the release of acetylcholine in the synapse is stimulated by your black spider venom and inhibited by botulinum toxin. Okay, what are they? Stimulated by black spider venom and inhibited by what? Botulinum toxin. Okay, and apart from that, you have the acetylcholine which is in the synapse. Now, this entered acetylcholine will bind with the acetylcholine receptor, and we are having a two types of acetylcholine receptor, people. What are they? Nicotinic receptor and muscarinic receptor. Okay, what are the two classes of acetylcholine receptors? Nicotinic receptors and muscarinic receptors. Till now I am repeating. So choline from outside is transported inside via the transporter which takes sodium along with it, which is inhibited by mityrosine. And now the entered choline will be combining with the acetyl-CoA and converts into acetylcholine mediated by choline acetyl transferase, which is a rate limiting step. And now the formed acetylcholine will be incorporated into the synaptic vesicle, and incorporation is inhibited by besamicol. And then once the action potential arrives, calcium influx will happen. The acetylcholine in the synaptic vesicle is released into the synapse. The release of acetylcholine in the synapse is inhibited by botulinum toxin and stimulated by black spider venom. Entered acetylcholine will be converted into, so will be bound with the acetylcholine receptor for the action. We are having two types of acetylcholine receptor. What are they? Nicotinic and muscarinic. Nicotinic and muscarinic. Among that, nicotinic receptor is your voltage gated ion channel receptor. Nicotinic receptor is your voltage gated ion channel receptor, which is containing two types, NM and NN. Okay, which is divided into two types, which is a NM and NN, where NM receptors are so called as neuromuscular, which is located in neuromuscular junction, while NN receptors are located in ganglia and adrenal medulla. Ganglia and adrenal medulla, while your neuromuscular junction NM receptors are inhibited by a South American arrowhead poison called as curare. So this is all about the nicotinic receptor. What type of receptor is a nicotinic receptor? Voltage gated ion channel receptor. What are the two types? NM and N. Okay, NM is located in neuromuscular junction, inhibited by South American arrowhead poison called as curare. NN is located in autonomic ganglia and adrenal medulla. Autonomic ganglia and adrenal medulla. Then you have a muscarinic receptor. Speaking about the muscarinic receptor, which is a G protein coupled receptor, where you see M1, M2, M3 as a subtype. Till M5 we are having, but among that M1, M2, M3 is very, very important. M1, M2, M3 is very, very important. So M1 receptors are present in gastric ganglia, and then it will be present in CNS. And M2 receptor, heart, and in the CNS. M3 receptor, where you see it in the eye, bladder, bronchus, GIT, gastric glands, and CNS. Okay, among that, your M1 and M3 receptors are GQ type. So GQ type means it activates what, people? GQ type means it activates what? It's a GQ type of receptor. That means it activates what? Faster, faster. It activates phospholipase C. Okay. And then M2 receptor is your GA receptor. M2 receptor is your GA receptor. So we are having a drugs where selective M1 blockers are pyrenzipine and telanzipine. Pyrenzipine and telanzipine. M2 blockers are tripyramine, and M3 blockers are your darifenazine. M3 blockers are your darifenazine. These are the selective blockers of your M1, M2, M3. Selective blockers of your M1, M2, and M3. Then you are having a then this acetylcholine, after producing its action, it may unbind and then it is broken down into acetate and choline, people. It may broken down into acetate and choline mediated by acetylcholine esterase enzyme. ACHE was the enzyme which is mediating it. Very important MCQ. Okay, ACHE inhibitors are the indirect acting cholinergic agonist. ACHE inhibitors are the indirect acting cholinergic agonist, where it is categorized as reversible and irreversible. Where it is categorized as reversible and irreversible. So the reversible ones are further classified into water soluble and lipid soluble. We will discuss that later. While the irreversible ones are your organic phosphate poisoning and carbamate poisoning. Organic phosphate poisoning and carbamate poisoning. So antidote for your organic phosphate and carbamate poisoning is your atropine. Your atropine is the antidote. And organic phosphate poisoning, you can give a oxime such as pralidoxime. But remember or write it as a note. Remember or write it as a note here. Oximes will not work in carbamate poisoning. Oximes will not work in carbamate poisoning. Write it and remember it. Oximes will not work in carbamate poisoning. Remember that. Okay, then you have a lipid soluble and water soluble. Lipid soluble ones are your tacrine, donepezil, rivastigmine, galantamine, and your physostigmine. While your water soluble ones are your edrophonium, pyridostigmine, and neostigmine. Edrophonium, pyridostigmine, and neostigmine. Okay, edrophonium, pyridostigmine, and neostigmine. Among that, your edrophonium is used for the diagnosis of myasthenia gravis, people. Among that, your edrophonium is used for the diagnosis of myasthenia gravis. Very important MCQ. Edrophonium is used for diagnosis of myasthenia gravis. Diagnosis of myasthenia gravis. And the test we use is your tensilon test. Okay. Then pyridostigmine and neostigmine, it acts on both nicotinic and muscarinic receptor. So nicotinic actions are used as a skeletal muscular relaxant, treatment of your skeletal muscle paralysis in your cobra bite, and it is also used for the treatment of myasthenia gravis. While muscarinic one, it is a post-operative uses. It is used for the treatment of your post-operative paralytic ileus and post-operative urinary retention. Post-operative paralytic ileus and post-operative urinary retention. Okay. So this is all about the one you have to remember here, people. This is all about the one you have to remember here. Okay. In the case of this flow chart is kind of like your own thing. Okay. And apart from that common side effect, activation of parasympathetic. What are the things you will get? You will get a dumbbells, diarrhea, frequent urination, meiosis, bronchoconstriction, bradycardia, emesis, lacrimation, salivation, and sweating. Lacrimation, salivation, and sweating are the common side effect of your cholinergic agonist. Okay, so with this we have completed your cholinergic agonist. With this we have completed your cholinergic agonist, which is your direct and indirect acting one. Okay, so treatment of belladonna poisoning, it is a physostigmine. Galantamine, tacrine, donepezil, rivastigmine are all used for the Alzheimer's. Among the tacrine is hepatotoxic, hence used not nowadays. Tacrine is not used nowadays. Not used nowadays. Okay, tacrine is not used nowadays. Then, speaking about the cholinergic blockers, the first one is your non-selective and organ-wise action. So non-selective one is your atropine, where it is a non-selective cholinergic antagonist which is used for the treatment of three poisoning: OP poisoning, carbamate poisoning, and early mushroom poisoning. Very, 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 very important. So atropine is a treatment of choice or drug of choice for three poisoning. What are they? OP poisoning, carbamate poisoning, and you have the early mushroom poisoning. And you have this early mushroom poisoning. Then you have a hyoscine, which induces the twilight sleep, since it is used as a truth serum. Hence, it is used as a truth serum to detect the lies. And then in the case of your organ-wise action, CNS, atropine is a CNS stimulant, scopolamine, motion sickness, and bromo, benztropine and trihexyphenidyl is for Parkinson disease. I used to remember with the mnemonic of park my Benz. Drug of choice for Parkinson, drug-induced Parkinson disease is your benzexol, which is a combination of benztropine and trihexyphenidyl. Okay, and then you have a ICE. So speaking about the ICE, atropine is the longest acting mydriatic, while tropicamide is the shortest acting mydriatic. Both of them are contraindicated in glaucoma. Okay, both of them are contraindicated in glaucoma. Then CVS, atropine low dose can produce bradycardia, while high dose can produce tachycardia. And respiratory, ipratropium and tiotropium, bronchodilators in COPD patient. Among that, tiotropium is not now used nowadays because of its hepatotoxicity. Okay, then you have a urinary tract, soft bladders are the drug, sulfenazine, oxybutynin, fexofenadine, fluoxate, tolteridone, trospium chloride. Okay, and darifenazine. All of them are used for the stress-induced urinary incontinence, people. All of them are used for the stress-induced urinary incontinence. Then you have a GIT, pyranzapine and telanzapine used for the treatment of peptic ulcer disease, and hyoscine, motion sickness, again, antispasmodic agent. So this is all about the cholinergic agonist and antagonist. So antagonist, atropine is a main drug, which is a non-selective cholinergic antagonist used for the treatment of drug of choice for OP poisoning, drug of choice for carbamate poisoning, drug of choice for early mushroom poisoning. It is a CNS stimulant. It is the longest acting mydriatic. At a low dose, it can produce brady, and at a high dose, it can produce tachy. Okay, then you have this, hyoscine, which is which induces twilight sleep. Hence, it is used as a truth serum. Okay, then scopolamine, motion sickness. Benztropine and trihexyphenidyl, drug-induced Parkinson disease. Drug of choice for drug-induced Parkinson disease. And then you have the I. Atropine is the longest acting mydriatic, while tropicamide is the shortest acting mydriatic. Okay. And apart from the respiratory, IPRA and tiotropium, both are bronchodilators in COPD patient. Among that, you have the hepatotoxicity in a tiotropium. Then urinary tract, urinary incontinence one, where you can use a sulfenazine, oxybutynin, fexofenadine, fluoxate, fesoteridone, fluoxate, tolteridone, and trospium chloride. In the case of GIT, pyranzapine and telanzapine, we can use this for the treatment of peptic ulcer disease. We can use for the treatment of peptic ulcer disease. So far, we have done your cholinergic agonist and antagonist, people. So far, we have done the cholinergic agonist and antagonist. So take a break of 10 minutes, come back by 6:10, where we do the adrenergic agonist and antagonist part. Where we do the adrenergic agonist and antagonist part. So take a break of 10 minutes and come back by 5:10. Sorry, 6:10. Okay, take a break of 10 minutes and come back by 6:10 so that we can able to discuss about the adrenergic antagonist. So, very good evening, everybody. So, we are resuming our session. So, till now we have talked about was the general physiology and the cholinergic agonist and antagonist. So, the next area of interest we are going to talk about is your next area of interest we're going to talk about is your adrenergic neurotransmission, where you see adrenergic adrenergic agonist as well as adrenergic antagonist. So we're going to talk about all of the important things which is related to the adrenergic neurotransmitter people, which is related to the adrenergic neurotransmission. You have to remember this here. So first one is your tyrosine. Tyrosine from outside is transported inside via the transporter, which takes sodium along with it. So this is a tyrosine. Tyrosine from outside to inside will be transported by your transporter, which takes sodium along with it, and entered tyrosine will be converted into DOPA. Entered tyrosine will be converted into DOPA by the tyrosine hydroxylase, which requires tetrahydrobiopterin as a cofactor. This tyrosine hydroxylase enzyme is inhibited by mityrosine. What is the drug? Mityrosine inhibits tyrosine hydroxylase, people. Okay, where the tyrosine from outside to inside will be transported by the transporter, which takes sodium along with it. Once it enters, the tyrosine will be converted into DOPA by tyrosine hydroxylase, which requires tetrahydrobiopterin as a cofactor inhibited by mityrosine. The entered DOPA will again further converted into dopamine by DOPA decarboxylase. Okay, will be converted into dopamine by DOPA decarboxylase, which is inhibited by your carbidopa, Now the formed dopamine will be incorporated into the synaptic vesicle, and this incorporation is inhibited by reserpine, tetrabenazine, valbenazine, and deutetrabenazine. Reserpine, tetrabenazine, valbenazine, and deutetrabenazine are the drugs which can able to prevent the incorporation of your dopamine into the synaptic vesicle. Now dopamine has been presenting in, and dopamine will be converted into adrenaline or noradrenaline. Dopamine will be converted into adrenaline or noradrenaline. Speaking about the adrenaline or noradrenaline, whenever the action potential arrives, then the calcium influx will happen, then the adrenaline will be released into the neurotransmitter. Yes or no? The release of adrenaline or noradrenaline into the neurotransmitter is inhibited by guanethidine and bretylium. Guanethidine and bretylium inhibits the release of neurotransmitter into the synapse, especially your adrenaline or noradrenaline. Okay, this is the presynaptic portion, people. Tyrosine from outside will be transported inside via the transporter, which takes sodium along with it. Entered tyrosine will be converted into DOPA, mediated by tyrosine hydroxylase, which requires tetrahydrobiopterin as a cofactor, inhibited by mityrosine. Entered DOPA will be converted into dopamine, mediated by DOPA decarboxylase, inhibited by carbidopa. Now the formed dopamine will be incorporated into the synaptic vesicle, where dopamine will be converted into adrenaline or noradrenaline. Incorporation of a dopamine into the synaptic vesicle is inhibited by reserpine, tetrabenazine, deutetrabenazine, and valbenazine. Then you have a dopamine will be converted into adrenaline or noradrenaline inside the synaptic vesicle. Whenever action potential arrives, calcium influx, then synaptic vesicles will release the neurotransmitter, which is your adrenaline or noradrenaline. Release of the neurotransmitter in the adrenaline or noradrenaline is inhibited by guanethidine and bretylium. So now what happens? Now the adrenaline or noradrenaline entered, and then they act on their receptors, and sometimes after the interaction, this adrenaline or noradrenaline will be it will be going back to their respective presynaptic neuron. So this respective presynaptic neuron into the via the reuptake mechanism. So this cocaine and TCAs will inhibit this reuptake of your adrenaline or noradrenaline inside the synapse. Okay, and once it has been inside the presynaptic neuron, it will be metabolized into their inactive metabolite by MAO enzyme. Okay, inhibited by MAO inhibitors. MAO inhibitors will inhibit this monoamine oxidase enzyme, which makes the adrenaline or noradrenaline into inactive metabolites. Okay, so now speaking about the presynaptic portion was over. Now the postsynaptic portion. Speaking about the postsynaptic portion, we are having an alpha and beta receptor. We are having an alpha receptor and beta receptor. So alpha receptors and beta receptors, speaking about that, beta receptors are all GS type of receptor. Beta receptors are all GS type of receptor, and alpha receptors are further classified into alpha 1 and 2, while alpha 1 and 2 are further classified into alpha 1A, alpha 1B, and alpha 2 are further classified into presynaptic and postsynaptic. Okay, presynaptic and postsynaptic. Speaking about the alpha 1 receptor, which is 1A receptor, which is present in prostatic urethra and your eyes, 1B blood vessels. Okay, alpha 1A receptors are present in prostatic urethra, alpha 2 blood vessels, while alpha 1B blood vessel, while alpha 2 presynaptic, which act like a brake to your sympathetic nervous system, while postsynaptic is present in blood vessels and brain. Postsynaptic is present in your blood vessels and brain. Then you have a beta 1 receptor, heart and JG cells, very, very important. And then beta 3 receptor, adipose tissue, coronary artery, urinary bladder. Adipose tissue, coronary artery, and urinary bladder. And beta 2 restal locations. So what are the types of receptors we are having? Alpha and beta receptors. Alpha 1, alpha 2, alpha 1A, alpha 1B, alpha 2 presynaptic, alpha 2 postsynaptic. Alpha 1A, prostatic urethra and eye. Alpha 2, alpha 1B, which is seen in the blood vessels. Presynaptic, brake to your sympathetic, and postsynaptic, which is present in the brain, blood vessels and brain. Beta 1, heart and JG cell. Beta 3, which is present in adipose tissue, coronary artery, urinary bladder. Rest all beta 2. Rest all beta 2. Remember, in blood vessels, I used to remember it like a ABCD of a mnemonic. Alpha 1, which is present in constriction, which causes vasoconstriction. Beta 2, which is causing a vasodilation. You can remember accordingly what type of thing is producing what type of net effect. Okay, this is the adrenergic neurotransmission, people. So far clear about the adrenergic neurotransmission. Shall I move on to the adrenergic agonist? Shall I move on to the adrenergic agonist? If we see adrenergic agonist and adrenergic antagonist, our ANS portion is over. We proceed to the CNS. ANS is very, very important that you have to remember most of the steps. While CNS, it is not like that. You can remember the CNS and CBS, you can remember very less stuff. Okay. So shall we move on to the adrenergic agonist? Shall we move on to adrenergic agonist? Speaking about the adrenergic agonist, which is of direct acting and indirect acting, people. Direct acting and indirect acting. Speaking of the direct acting one, exogenous and endogenous adrenergic agonist. Exogenous ones are your dobutamine, dopexamine, phenaldopam, and isoprenaline, while endogenous ones are your dopamine, adrenaline, and noradrenaline. Okay, dopamine, adrenaline, and noradrenaline, while adrenaline 1 act on the beta receptors, while noradrenaline act on alpha 1 receptor at first. We are talking about the receptor preference. Okay, speaking about the adrenaline, adrenaline is a drug of choice for anaphylactic shock, where you used to give 0.5 ml in 1:10,000 solution in IMR subcutaneous. Okay, sorry, 1:1000 solution in IMR subcutaneous. 1:10,000 solution IV is given only for one indication, that is your CPR for resuscitation, because never ever give the IV adrenaline to the live patient. Patient dies. Okay, the only indication is during the CPR for the resuscitation. You should keep that in mind, as I said in the class already. Okay, then you have a dobutamine. Dobutamine is a cardioselective one, which is used for the treatment of congestive heart failure. Phenaldopam is used for the treatment of hypertensive emergencies. Then dopamine. Dopamine is used for the treatment of cardiogenic shock with the oliguria. Cardiogenic shock with the oliguria, dopamine is a drug of choice. And dosage and the receptor activity are pretty high yield important questions. So speaking about 1 to 2 microgram per kg per minute, it acts on D1 receptor. If you increase the dose to 2 to 10, it acts on beta 1 receptor. If you increase the dose more than 10, it acts on alpha 1 receptor. Okay. So 1 to 2, D1 receptor, 2 to 10, beta 1 receptor, more than 10, which is alpha 1 receptor. More than 10, which is your alpha 1 receptor. So you have to remember that adrenergic direct acting agonist 1, and then you have to remember that drug of choice for anaphylactic shock is adrenaline. Okay, drug of choice for cardiogenic shock with the oliguria. Okay, drug of choice for cardiogenic shock with the oliguria. It is dopamine. It is dopamine. So dopamine act on D1 receptors, while adrenaline act on beta receptors, while noradrenaline act on alpha receptors. Then you have the indirect acting ones. One is your reuptake inhibitors like a TCA and a cocaine. Cocaine is commonly called as snow or speed, which is used as a local anesthetic in ocular surgery or neck surgery or some other surgery. We studied about cocaine in our anesthesiology, so I don't want to insist much here. Then we talked about the displacement drug. So first one is your tyramine. Tyramine on addition with the MAO inhibitor can produce cheese reaction, people. Can produce cheese reaction. Very, 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 very important MCQ. Tyramine on addition with the MAO inhibitor, it can produce cheese reaction. It can produce cheese reaction. Then you have a modafinil, drug of choice for narcolepsy, methylphenidate, drug of choice for ADHD, another important MCQ. Then you have ephedrine, which is a bronchodilator and nasal decongestant, and it is a vasopressor of choice in pregnancy. And it is a vasopressor of choice in pregnancy. Okay. Then you have non-catecholamine agonist, which is a receptor selective agonist, people. Alpha 1 agonist are xylymetazoline, oxymetazoline, and naproxolone. All the zolens used as a nasal decongestant. All the zolens used as nasal decongestant. And apart from that, phenylephrine, which is a mydriatic and not cycloplegic. And then you have a midodrine, methoxamine, and mephenteramine. Mephenteramine causes increase in BP in a hypertensive crisis, and midodrine is a prodrug. Midodrine is a prodrug, and mephenteramine is an increase in BP in hypertensive crisis. And alpha 2 agonist, we are having clonidine, alpha methyl dopa, aproclonidine, brominidine, and dexmedetomidine, and tizanidine. All the nidines: clonidine, aproclonidine, brimonidine, dexmedetomidine, and tizanidine. All of them is used for the treatment of glaucoma. Among that, your clonidine is used for the ADHD as well as prophylaxis of migraine. Very, 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 very important MCQ. Which alpha 2 agonist used as a prophylaxis of migraine? Which is your clonidine. Which is your clonidine. And apart from that, tizanidine is a muscular relaxant. You may have to remember that. Then you have a beta 1 agonist, prenatrinal, which is used for the reversal of beta blocker activity. And beta 2, SABA or LABA, bronchial asthma, ridotin and ixazopine, which is a tocolytics, and beta 3, mirabegron, which is used for the treatment of overreactive bladder, So far, this is the one, people. Okay, so far, this is the one. Okay, so what are the things you have to know? One is your direct acting, indirect acting. Direct acting, exogenous, endogenous. Endogenous ones are dopamine, adrenaline, noradrenaline. While exogenous ones are your dobutamine, dopexamine, phenyldopamine, isoprotrinol or isoprenaline. However, your book's calling it, you can call it. So dopamine specifies D1 receptor, adrenaline specifies beta over alpha, and apart from that, noradrenaline specifies alpha 1 over beta 2. Okay, alpha 1 over alpha 2, then beta 2. Okay, now speaking about that, the adrenaline, drug of choice for anaphylactic shock, and dopamine, drug of choice for cardiogenic shock with the oliguria. Dopamine on the dosage of 1 to 2 microgram act on D1 receptor, 2 to 10 act on beta, and more than 10 act on alpha. Then alpha 1 agonist, selective agonist. So we are having 3 categories. One is your mydriatic one, hypotensive crisis one, nasal decongestion one. Okay, hypertensive crisis ones are your mephenteramine, midodrine, and methoxamine, while your mydriatic ones is your phenylephrine, and nasal decongestions are all your metazolines. Okay, oxymetazoline, xylymetazoline, and nefazolines, all the zolines will be the nasal decongestant, which is a selective alpha 1 agonist. Alpha 2, clonidine, used for treatment of ADHD and prophylaxis of migraine, and tizanidine, muscular relaxant. Then beta 1, prenatrinol, beta blocker reversal, beta 2, SABA and LABA, and you have this ritodin and ixazepine, which is a tocolytic. SABA and LABA is for bronchial asthma. Then you have this beta 3, mirabegron, which is used for the treatment of overreactive bladder. So selective, non-selective, direct acting, indirect acting, exogenous, endogenous, all type of alpha stimulating activity, alpha adrenergic stimulating activity has been done. Now we are moving on to adrenergic inhibitory activity. Okay, adrenergic antagonist. Adrenergic antagonist. Speaking about the adrenergic antagonist, we are having this alpha blockers. So non-selective and selective alpha blockers. So we first talk about the non-selective one. Non-selective ones are of irreversible and reversible. Irreversible and reversible. Irreversible one is a phenoxybenzamine, which is a drug of choice for pheochromocytoma, where you see increased VMA in urine, vanillin mandelic acid in urine. Increased vanillin mandelic acid in urine is seen in pheochromocytoma, which is a drug of choice is phenoxybenzamine. Drug of choice is phenoxybenzamine. Then you have a vasodilation, treatment of hypertensive crisis, and reversible one, you have a phentolamine and a tolazolin. Reversible one, you have a phentolamine and tolazolin, used for the treatment of hypertensive crisis and clonidine withdrawal, and drug of choice for rebound hypertension. And drug of choice for rebound hypertension and treatment for cheese reaction, along with MAO inhibitors and tyramine can cause a cheese reaction that could be revertible by phentolamine. Okay, that could be reverted by phentolamine. Okay, very important, which is your reversible one. Okay, irreversible one is phenoxybenzamine, pheochromocytoma, where you see increased vanillin mandelic acid level. Okay, then selective alpha blocker, alpha 1, all the zosins, prazosin, doxazosin, terazosin, tamsulosin, and so on, all of them are used for the treatment of BPH. Selective alpha 1 blockers are used for the treatment of BPH. Very important. Okay, and among that, prazosin is also used for the treatment of scorpion sting, which was a high yield MCQ. And tamsulosin side effect is your floppy iris syndrome, and it is used in the cataract surgery. Okay, it can cause a iritis in the cataract surgery. Okay, then you have this alpha 2 blockers, yohimbine, used for the treatment of your alpha 3 blocker, which is your yohimbine, which is used for the treatment of your erectile dysfunction. Then you have a beta blocker, first gen, which is a non-selective, second gen, which is selective, third gen, which is a beta blocker with the additional activity. Beta blockers with the additional activity. So beta blockers, variety of beta blockers, and their names are there. First gen, second gen, which one is cardioselective, which one is intrinsic activity, everything was there. If you want to mug up. Okay, if you want to get that 1 mark from the beta blockers, then you mug up and get. I listed out here. Well, I'm not a mugging up guy. So if you are good enough to mug up, then you mug up. Okay, but I gave you the mnemonics to remember. Okay, so first one, first generation, 3 P's are not stable today. 3 P's are not stable today. What are the 3 P's which are not stable today? The 3 P's are your propanolol, penbutylol, and pindolol. Propanolol, penbutylol, and pindolol are the 3 P's, and N stands for nadolol, S stands for sotalol, and T stands for timolol. Nadolol, sotalol, timolol, and propanolol, penbutanol, and pindolol. Okay, then you have a cardioselective. You have the second generation cardioselective ones. New beta blockers act exclusively at myocardium. Very important MCQ. N stands for nebivolol, and B stands for bitoxolol, another B bisoprolol, and A stands for acebutolol, and T act exclusively. E stands for esmolol, and A stands for atenolol, M stands for metoprolol, and C stands for celiprolol. Okay, nebivolol, bitoxolol, bisoprolol, acebutolol, esmolol, atenolol, metoprolol, and celiprolol. And one with the intrinsic activity, I used to remember with the mnemonic of ANSI controls Priya's agony, alpranolol, celiprolol, oxpranolol, Pindolol, penbutolol, and acebutolol. Pindolol, penbutolol, and acebutolol. Then having a membrane stabilizing activity, party pays for MLA, P stands for propanolol, P stands for pindolol, MLA, metoprolol, labetalol, and acebutolol. Metoprolol, labetalol, and acebutolol. Apart from the lipid insolubility one, all biotic containers are not soluble. A stands for atenolol and acebutolol. B stands for bitoxolol and bisoprolol. C stands for celiprolol. N stands for nodolol. S stands for sotalol. S stands for sotalol. Then third generation, love care connections are basically new business. What is the third generation mnemonic? Love care connections are basically new business. L stands for labetalol. C stands for carvedilol, and another C stands for celiprolol, and B stands for buzindolol, and N stands for nebivolol, and another B stands for beventolol. Another B stands for beventolol. So labetalol, carvedilol, celiprolol, buzindolol, nebivolol, and beventolol are the third generation one. So we have the alpha blockers, beta blockers, alpha agonists, beta agonists, selective, non-selective, all the things, reversible, irreversible, exogenous, endogenous, all the adrenergic neurotransmission has been done, people. All the adrenergic neurotransmission has been done. Okay, however you want to read it, read it. Okay, but this is pretty important where you expect 2 to 3 questions in this 2 pages. Okay, so I just made it like a 3 pages so that you can able to understand or grasp most of the things. Okay, shall I move on to the next area of interest, people, which is your CNS? Shall I move on to the next area of interest, which is your CNS? Okay. Now speaking about the CNS pharmacology. Now speaking about the CNS pharmacology, the very first one is your anti-Parkinson drugs, people. The very first one we are going to talk about is your anti-Parkinson drugs. Anti-Parkinson drugs. So what are the anti-Parkinson drugs and their mechanism of action? Very, very important ones we're going to discuss about it. Treatment for drug-induced Parkinson disease, it is benzexol. It is benzexol or acetylcholine antagonist. I told you already the mnemonic. Mnemonic is park my benz. What is the mnemonic? Park my benz is the mnemonic. Okay, you should not miss it. Then you have the drug which can increase your dopamine concentration. So one is your levodopa, which is also a prodrug, which is a dopamine analog, which is a prodrug, levodopa, and carbidopa, which is a peripheral dopa decarboxylase inhibitor, entacapone or tolcapone, which is a COMT inhibitor, selagelin or rasagelin, which is a MAOB inhibitor, and bromocriptine as a D2 agonist. So strategy for your, Parkinson diseases. Number one, the Parkinson disease is due to destruction of dopaminergic neuron in nigrostriatal pathway. Yes or no? Destruction of dopaminergic neuron in nigrostriatal pathway is so called as Parkinson disease. In nigrostriatal pathway is so called as Parkinson disease. Okay. So how do you solve the problems of the symptoms of Parkinson disease? By increasing the dopamine concentration. How do you solve it? Increase in dopamine concentration. How do you increase it? Dopamine cannot able to cross BBB, cannot cross BBB. So we give a levodopa, which can go to brain and converts into dopamine, and then it increases the concentration. Okay, dopamine and increases the concentration. But there is a chance this levodopa may be peripherally converted into dopamine, so that brain cannot able to utilize this dopamine. So this peripheral conversion we have to inhibit. So what are the 3 possible peripheral conversion? One is your peripheral dopa to dopamine conversion mediated by carbidopa. Enzyme is dopamine decarboxylase. We inhibit by using a carbidopa. And apart from that, you have the levodopa, which will be converted into CO-methyl dopa or 3-O-methyl dopa mediated by COMT, catecholamine O-methyl transferase enzyme. So entacapone or tolcapone is a drug which inhibits this. And then you have the metabolism of your dopamine inside your brain prior moving on to the nigrous striatal pathway mediated by MAO type B in enzyme. So MAO type B inhibitors like selagelin or rasagelin we can give, or we can activate the dopamine receptor by giving a dopamine analogs like bromocriptine, apomorphine, rotigotine, and so on. Okay, bromocriptine, apomorphine, rotigotine, and so on. We can give it for the this type of thing. Okay, to increases the dopamine concentration, or else we have to decrease the acetylcholine concentration because we have to maintain the balance between dopamine and acetylcholine. So you have to give either acetylcholine inhibitors or you have to give a dopamine inducers. So acetylcholine inhibitors is for drug induced one where you use the benzexol, parc-my-benz, which is a combination of benztrophin and trihexyphenidyl, which we studied in the cholinergic antagonism, which is used for the treatment of drug-induced Parkinson disease. We have studied that already. Okay, we have studied that already. So far clear, people? Parkinson. Then you have anti-epileptics. Then you have anti-epileptics. Speaking about the anti-epileptics, so we know that the what is meant by epilepsy, people? What is meant by epilepsy? Abnormal electric conduction which results in the involuntary contraction of your muscle. Yes or no? So what is that? Due to the electrical imbalance. Yes or no? Action potential ion imbalance, you may get the seizures. It is proposed theory. So if you are suppressing your excitatory neurotransmitter is suppressed, and if you enhance the inhibitory, we can able to get this thing, no? Yes or no? We can able to control the seizures, right? Why is the seizure is happening? The seizure is happening for two things. What are they? The seizure is happening for two things. What are they? Due to the abnormal contraction. Whenever you see there is more excitatory neurotransmitter, then the contraction will be powerful, contraction will be abnormal. So treatment of strategy could rely on either you inhibit the excitatory neurotransmitter one, or you enhance the inhibitory neurotransmitter one. You can able to solve the seizures, right? Yes or no? You can able to solve the seizures. So we are having a variety of drugs with a variety of mechanism of action. But how do you remember for the FMGE? Very, very important thing to remember for FMGE is if you see any seizure type, if you are seeing any seizure type except status epilepticus or Lennox-Gastaut syndrome or maybe juvenile West syndrome or infantile spasm, any abnormal epilepsies, okay, except status epilepticus, blindly choose sodium valproate, people. Okay, blindly choose sodium valproate as a drug of choice. If they are asking you drug of choice, all type of seizure except status epilepticus, put sodium valproate as a drug of choice. Okay, and for the status epilepticus, you have to give a lorazepam. Okay, you have to give a lorazepam as a drug of choice. But why we need to study about the anti-epileptics for the revision is like we need to know there are certain important side effects which has been caused by these drugs. That is very, very important. Okay, one which is blocking the sodium voltage gated sodium channels are your phenytoin, sodium valproate, and then you have a topiramate, and then you have a lamotrigine, and then you have a carbamazepine and lacosamide. What are the drugs? Phenytoin, sodium valproate, topiramate, lamotrigine, carbamazepine, and lacosamide are the drugs where we used to block the sodium voltage gated sodium channels. Voltage gated sodium channels. Okay, fine. What are the side effects of your phenytoin? What are the side effects of your phenytoin? Very, 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 very important is this three. Hirsutism, gingival hyperplasia, and fetal Hayden-Toyen syndrome. Classical side effect, which we had asked several times in past FMG papers are this three. Okay. What are the classical side effect of phenytoin? What are the classical side effect of phenytoin? Hirsutism, gingival hyperplasia, and fetal Hayden-Toyen syndrome. Apart from that, phenytoin follows zero order kinetics. Another classical important MCQ. Phenytoin follows zero order kinetics. Okay, phenytoin follows zero order kinetics. Then sodium valproate. mechanism of action is blocking of sodium, calcium, and enhancement of GABA. All the things it will do. Drug of choice is very, very important. All type of seizure, generalized tonic-clonic, myoclonic, absence seizure, clonic seizure, tonic seizure, Lena-Gestalt syndrome, and rapid cycles in bipolar disorder. Nowadays, this is a classical choice of question that may have been asking in the FMGE. Okay, what is a drug of choice for rapid cycle in bipolar disorder patient? What is the drug of choice for rapid cycles in bipolar disorder patient? Which is your sodium valproate, and it is used for the treatment of West syndrome or juvenile infantile spasms, or it is also used for the treatment of trigeminal neuralgia. Remember, treatment, not the drug of choice. Okay, treatment, not the drug of choice. Side effect, PCOD, teratogenic, agranulocytosis are the three classical one you have to remember. So anti-epileptic, two things we have studied. What are they? Phenytoin, and we have studied sodium valproate. Any seizure, put a sodium valproate, except infantile spasms and status epilepticus and trigeminal neuralgia. Okay, and most important side effect of your sodium valproate is PCOD, and it is also teratogenic, and it can cause agranulocytosis. Okay, phenytoin, zero order kinetics, hirsutism, gingival hyperplasia, fetal Hayden-Toyen syndrome. Okay, fetal Hayden-Toyen syndrome are the three things where you have to remember, people. Where you have to remember. Then you have a topramate. So speaking of a topramate is having a multiple mechanism of action. Okay, and it is a CYP2C19. Remember, mechanism of action of topramate is it can produce anything. Okay, then you have a lamotrigine. Speaking of a lamotrigine, it is also a wide spectrum anti-epileptic. One of the important side effects for lamotrigine is Stevens-Johnson syndrome, toxic epidermal necrolysis are the two things you should not forget whenever it comes for the lamotrigine. Okay, whenever it comes for the lamotrigine, what is the thing you have to remember, people? Stevens-Johnson syndrome and 10. Toxic epidermal necrolysis are the side effects of lamotrigine. When it comes for the PCOD or agranulocytosis, it is a sodium valproate. When it comes for the hirsutism, gingival hyperplasia, fetal Hayden-Toyen syndrome, then it is a phenytoin. Okay, then you have a carbamazepine. Carbamazepine is a drug of choice for focal seizure and trigeminal neuralgia. So rapid cyclers in bipolar disorder, it is a sodium valproate. Drug of choice for focal seizure, it is a carbamazepine. Drug of choice for any generalized seizure, it is your sodium valproate. Drug of choice for trigeminal neuralgia, it is your carbamazepine. Which drug causes Stevens-Johnson syndrome and toxic epidermal necrolysis? That is 10, which is your lamotrigine, which is a broad spectrum anti-epileptic where you use it as a first line of choice. Okay, while we talk about the epilepsy and management of epilepsy in the medicine session. Okay, now apart from that, you have drugs which can block the voltage gated calcium channels. So voltage gated calcium channels, it is a ethosuximide, valproate, and lamotrigine. We already discussed about valproate and lamotrigine. So only drug we discuss here is ethosuximide, which is a drug of choice for absence seizure in less than 2-year-old patient. If they are given you simply absence seizure, okay, if they are given you simply absence seizure, as I said, any type of generalized seizure, choose sodium valproate. If they are specifically mentioned you with the less than 2 years, then you choose a ethosuximide. Okay, then you have a BZDs and a barbiturate, which enhances the GABA activity, and then vigabatrin. So BZDs, enhancement of GABA activity, but how? Increase in frequency of opening of chloride channel. How is it rising? Increase in frequency of opening of your chloride channel. What are the classification? Short acting, medium acting, and long acting. Among that, oxazolum and triazolam is a short acting one. Okay, while temazepam is a medium acting one, and quazepam and diazepam is a long acting one. Among that, one time in FMGE they asked this as a question: rectal diazepam. Okay, write it down as this. Rectal diazepam is used for the treatment of is used for the treatment of your febrile seizures. For febrile seizure, they used a rectal route of diazepam for the treatment. One time they asked this as a question in FMGE. Make sure you know that too. Okay, speaking about the diazepam, which is a long-acting benzodiazepine. Okay, what is the mechanism of action of benzodiazepine? Increase in frequency of opening of chloride channel. While barbiturate, it exactly does the another one. Increase in duration of opening. While benzodiazepine increases frequency of opening, while barbiturate increases duration of opening. Okay, how is it? Duration of opening, and it enhances the GABA activity. Among the classification, ultra short, short, and long acting. So ultra short acting one is a thiopental, while long acting one is your phenobarbital. Side effects, which is a idiosyncratic reactions, and then you have a hangover effect, and then coma. And remember one thing, barbiturates, it is contraindicated in AIP. Very, 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 very important MCQ. Barbiturates are contraindicated in acute intermittent porphyria, and antidote for benzodiazepine poisoning is flumazenil. Antidote for benzodiazepine poisoning is flumazenil. Very, 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 very important MCQ. BZD poisoning, flumazenil. OP poisoning, atropine. Carbamate poisoning, atropine. Belladonna poisoning, physostigmine. Early mushroom poisoning, atropine. And you have to remember most of the thing. Drug of choice for cardiogenic shock with the oliguria, dopamine. Drug of choice for anaphylactic shock, it is your drug of choice for anaphylactic shock, it is your adrenaline. And drug of choice for pheochromocytoma, which is your phenoxybenzamine. MAO inhibitors along with the dash can cause the cheese reaction, tyramine. Drug of choice for cheese reaction, pentolamine. Drug of choice for myasthenia gravis, neostigmine and pyridostigmine. Drug of choice for, what is the diagnosis of myasthenia gravis? Hydrophonium. Drug of choice for Alzheimer's disease, tacrine, donepezil, rivastigmine, galantamine. Among that, which one is not used nowadays? Tacrine is not used nowadays. Okay, you should know every single thing, people. Okay, Steven-Johnson syndrome is a side effect of lamotrigine. 10 is a side effect of lamotrigine. Benzodiazepine mechanism of action, increase in frequency of opening of chloride channel. Barbiturate mechanism of action is increase in the duration of opening of your chloride channel. Barbiturates, no antidote. Benzodiazepine, flumazenil is an antidote, and barbiturates contraindicated in acute intermittent porphyria patient. Rapid cyclers in bipolar disorder, sodium valproate. But if they are asking you for the treatment of mania, it is lithium. Okay, what is the treatment of mania? It is a lithium. Still, the mechanism is unknown, but there are two proposed theory. One is the inhibition of IMP, lack of PIP to IP3 conversion, that in turn blocking the intrinsic activity. Another one is GSK3 receptor inhibition, where it can inhibit the brain-derived natriuretic factor. Then neuronal plasticity will be suppressed, and there is altered neurogenesis. This is the two proposed theory of your lithium mechanism of action. But so far, there is no still now the mechanism is unknown for lithium, which is used for the treatment of acute mania. Okay, for acute mania, dosage is 0.8 to 1.2, maintenance 0.5 to 0.8, and then for toxicity, more than 1.5, dialysis requirement, it is more than 4. Very, 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 very important MCQ, same like a dopamine dosage in respect to the receptors. You have the lithium dosage for the various situations is very, very important. 0.5 to 0.8 maintenance dose. Acute episode 0.8 to 1. Toxicity more than 1.5. Dialysis requirement more than 4. Okay, more than 4. Okay. Then this is for the mania. Then for the depression, SSRIs. Important one is your fluoxetine, escitalopram, fluoxamine, sertraline, and paroxetine. All the zetins and zamines. Okay, fluoxetine, paroxetine, escitalopram, citalopram, sertraline, all those things is a selective serotonin reuptake inhibitors. So any depression or any psychiatric disorder, if they are quoting you, blindly choose SSRIs you find. Okay, blindly choose SSRIs you find. Similarly, like how I am saying you, blindly choose a sodium valproate whenever you see the generalized seizure episode, blindly choose a sodium valproate. Similarly, if you are finding any psychiatric disorders, except the maniac predominantly, choose SSRIs. Whatever the SSRIs you are finding, choose it directly. Okay, for example, SSRIs is a drug of choice for all type of psychiatric disorders, like a generalized anxiety, socialized anxiety, post-traumatic stress disorder, depression, bulimia nervosa, anorexia nervosa, premenstrual dysphoric disorder, anything that can come into the depression or psychiatric condition, put blindly SSRI. See the SSRI and choose it wisely. Okay. For that, you have to remember SSRI drugs. Okay. So, Sir said SSRI, there is no SSRI was there. Only fluoxetine was given there. So, that is your mistake. Okay. So, you have to remember the drugs which comes under the SSRIs too. Okay, then side effect, very important side effect is prolongation of QT interval. Very important. Prolongation of QT interval for SSRIs, serotonin syndrome associated with the MAO inhibitor type B. And apart from that, increase in suicidal tendency. Most people I see practically is sometimes when you are giving an overdose of your SSRIs, the patient tends to have a more amount of tendency of suicidal thoughts. They come and directly say us after a week or two, they come and they tell us like, sir, I'm having an excessive suicidal thought. I don't know what to do. Then immediately that is a warning sign that you have to shift the SSRI to SNRI or MAOB inhibitors. Okay, MAO inhibitors. Okay. Then apart from that, antipsychotics. So speaking about the antipsychotics, you are having a typical and atypical antipsychotics. Typical antipsychotics will only block D2 activity, while atypical D2 blocking along with the additional activity. D2 blocking along with the additional activity. For a typical, only positive symptoms can be treated. And for atypical, both positive and negative symptoms can be treated. Both positive and negative symptoms can be treated, and extrapyramidal symptoms are more common and typical, while decreased risk of extrapyramidal symptoms is seen in atypical. So which one is more effective for the antipsychotics? Atypical one. Okay, atypical one, where the side effect mostly hyperprolactinemia, sedation and seizure in terms of typical, while hyperglycemia, hyperlipidemia and metabolic side effects are seen in atypical antipsychotics. So this is all about the typical and atypical antipsychotics. So we have done your neurodegenerative disorders. We have done your anti-epileptics. We have done your benzodiazepine and barbiturates. We have done your antidepressants. We have done your antipsychotics. The only thing left over in the CNS is your anesthesia. And we have covered the anesthesia pharmacology in depth in the anesthesia video. So we don't no such extra questions will come from the anesthesia along with that video. If you master it, you can answer the anesthesia question too. So with that, we are completing the CNS. So far we have done with the general form, ANS and CNS. Shall I move on to the cardiovascular system, people? Shall I move on to the cardiovascular system? Shall I move on to the cardiovascular system? Okay. Speaking about the cardiovascular system, the first area you have to remember is your antiarrhythmics. So speaking about the antiarrhythmic, what are the things you have to remember in terms of antiarrhythmic? What are the things you have to remember in terms of antiarrhythmic? Like what sort of questions you may expect in the antiarrhythmic agents in your CVS? So they may ask you, they may give you the drug and they may ask which classes of drug that this one belongs to. Which classes of drug that this drug belongs to, they may ask you according to the Wagman and the Singh's classification, which class of the antiarrhythmic agent that this drug belongs to. Or they may give you one arrhythmias and they may ask you a drug of choice. So I covered here the both. Okay, if you know these two, then that is more than enough for the CVS and your anti-arrhythmias. Okay, arrhythmic area in your CVS. If you want a more in-depth lecture, then watch it on your pharmacology session, which was done in the classes. Okay. Then first one is your anti-arrhythmic one, class 1A, where you see class 1 is your sodium channel blockers, where you see class 1 is further subclassified as A, B, and C. Class 1A is disopramide, procainamide, and quinidine. Disopramide, procainamide, and quinidine. Class B is lidocaine and mexiletine. Class C is plicainide and propofenone. Class C is flecainide and propofenone. Apart from that, class 2, where you see the beta blockers, all the LOLs and beta blockers, all the list cardioselective beta blockers we have seen already. New beta blockers act exclusively at myocardium is the mnemonic for that. You can able to remember that. And the class 3 is your potassium channel blockers, which is your amiodarone, dofilitide, ibutylide, and sotalol. Dofilitide, ibutylide, and sotalol is the one where you have to remember as a class 3. And the class 4 calcium channel blocker, diltiazem and verapamil. Diltiazem and verapamil. So what is the class 1? Class 1A is for sodium channel blockers. Class 2 is beta blockers. Class 3 is potassium channel. Class 4 is calcium channel. Class 4 is calcium channel. Among that, class 1 is further classified into 1A, 1B, 1C. Among that, what are the drugs which belongs to 1A? Disopramide, procainamide, and quinidine. Class 1B is lidocaine and mexiletine. Class 1C is plicainide and propofenone. Class 2 is all the lows. That is you studied that in the ANS. That's why I didn't mention it. New beta blockers act exclusively at myocardium. And class 3 is amiodarone, dofilitide, ibutylide, and sotalol. And apart from that, class 4 is CCB, where you see the diltiazem and verapamil. Diltiazem and verapamil. Then what type of arrhythmias and what are the drug of choice for those arrhythmias? For a PSVT, paroxysmal supraventricular tachycardia, the arrhythmia of choice is adenosine. And VT or VF, the arrhythmia of choice is lignocaine. AF or atrial flutter, arrhythmia of choice is propanolol. Tarside is D-pointers, magnesium sulfate or Mg. Either a magnesium sulfate or MgSO4 you can able to do, or simply magnesium is a drug of choice. For your tarside is D-pointers. Digital is induced VT, lignocaine is a drug of choice. Very, 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 very important. This table is kind of like another 3-star to 5-star rated table where you have to remember. Okay. So what are they? So PSVT, drug of choice or arrhythmia of choice is adenosine. VT or VF, lignocaine. AF or atrial flutter, propanolol. Tarside is D-pointers, magnesium sulfate. Digital is induced VT, lignocaine. Digital is induced VT, we give a lignocaine. So far we have done the anti-arrhythmic agents. What type of drug belongs to what classes and what are the arrhythmias and drug of choice you have to remember. Then antihypertensive. So speaking about that, as per the hypertensive guideline, what is the first line of choice of drug in terms of your hypertension? Okay. What is the first line of choice of drug in terms of your hypertension? You have to remember, people. So the first line of choice is your thiazide diuretic. Very, 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 very important. Okay, thiazide diuretic. Apart from that, ACEIs and ARBs, followed by loop diuretic, followed by CCBs and beta blockers, and then finally vasodilator. This is the step of drug you have to initiate. Any patient comes to you with a newly diagnosed hypertension, the first drug you have to initiate is thiazide diuretic if you have no complication. Okay, if you have something like a renal failure and diuretics is contraindicated in that patient, then you can give a ACEAs and the ARBs. Then apart from that, you have a loop diuretic you can give, and then followed by anything which is not resolving, patient is having a multiple BP medications, you have to add one more. Then you can add a beta blockers or calcium channel blockers. Then you can give a vasodilators as a final choice. Okay, as a final choice. So we covered the diuretics. Now. So after the diuretics, we pass for the today's session. And tomorrow we will continue the remaining portion of pharmacology. So the last area of interest today is your diuretic. Last area of interest is your diuretics, where we cover the kidney portion and the cardiovascular system itself. So speaking about the diuretics, so we are having the nephron here. So you are having a diuretics which acts on PCT, diuretics which act on loop of Henle, diuretics which act on late DCT, and drugs which act on proximal DCT. Okay, drugs which act on proximal DCT. So this is kind of like a one-page one where you may expect a lot of questions from this. So what are the diuretics which acts on PCT people? What are the diuretics which acts on PCT? One is your carbonic anhydrase inhibitor. Another one is your osmotic diuretic. So first we talk about the osmotic and then we come to the carbonic anhydrase inhibitor. Okay. So speaking about the osmotic diuretic, the first one is your mannitol. It can create the osmotic gradients and then producing a diuresis, movement of your fluid. Okay, mainly used for decrease in intracranial pressure and intraocular pressure. Okay, decrease in intracranial pressure and intraocular pressure mainly. Apart from that, we can use a genitourinary irrigation and cisplatin-induced neuropathy, blah, blah, blah. But main thing is anything which can obstruct or causing elevated ICP and IOP, the first drug of choice you have to choose is your mannitol. But what are the side effects? It can produce a pulmonary edema. Hypovolemia and hypernatremia and hyperkalemia. Hypernatremia and hyperkalemia are the one which is produced by this osmotic diuretic. Very, 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 very important. Okay, what is the osmotic diuretic? It is acting on the PCT, creation of osmotic gradients, production of diuretic. The drug is mannitol. What is the usage? It decrease in intraocular pressure and a decrease in intracranial pressure. Side effects, pulmonary edema. Then you have a carbonic anhydrase. So carbonic anhydrase inhibitors are all the zolamides people, acetazolamide, darzolamide, brinzolamide, and so on. All the zolamides will be coming under the category of carbonic anhydrase. Why? All the zolens will come under the category of faster, keep your hands on keyboard, people. All the zolens will come under the category of selective alpha-1 agonists, which are the nasal decongestant. Okay, selective alpha-1 agonists, which are the nasal decongestant. You have to remember that. Okay, now carbonic anhydrase, acetazolamide and darzolamide. Mechanism of action is inhibition of carbonic anhydrase. So there is no decrease in H plus there is no H plus formation, no sodium H plus antipode. So sodium in lumen, which can produce as a diuretics. Okay, so main carbonic anhydrase inhibitors are used for edema due to congestive heart failure, Meniere's disease, angle closure glaucoma, and you have the acute motion sickness. Apart from that, absence issue. This Meniere's disease, edema due to congestive heart failure, and you have this angle closure glaucoma. All the three are pretty important. And side effect, hyperchloremia, hypokalemia, acidosis, and liver cirrhosis. So this is all about the osmotic diuretics and carbonic anhydrase inhibitors. Both act on the proximal convoluted tubule. Then you have a loop of Henle, where you see the loop diuretics, which is the most potent diuretics, where the drug is furosemide, bumetanide, and torsemide. Among that, furosemide is the most common. Most potent is bumetanide, and longest acting is torsemide. Remember always, whenever, because I see most of the students makes a mistake here, whenever they ask for loop diuretics, immediately they choose furosemide blindly. But remember one thing, most potent is never a furosemide, which is a bumetanide, and longest acting is torsemide. Even in the clinical setup, we give a torsemide first, and then we give a for an acute episode we give a furosemide. But for whenever we are sending the patient home, that's the time we put him on the long-acting loop diuretic, which is your torsemide. Okay, you have to understand that, because most people blindly chooses furosemide whenever they see the loop diuretic. Main mechanism of action is inhibition of sodium potassium 2 chloride transporter. Which can produce a diuresis, and drug interaction is associated with aminoglycoside, lithium, and digoxin. And the side effects, hypocalcemia, kalemia, hypomagnesemia, hyperuricemia, and ototoxicity. Hyperuricemia and ototoxicity. Then, apart from that, the drug which act on the early and late DCT. So, early DCT, it is a thiazide diuretics, which is a first line of treatment for the hypertension. Apart from that, it can be used as a drug of choice for Williams and Liddle syndrome, primary hyperparathyroidism, and then it is also used for the nephrogenic diabetes insipidus. Very important. Nephrogenic diabetes insipidus. Okay. Then all the thiazide, anything with the ending with the thiazide is your thiazide diuretic. Inhibition of sodium chloride transporter. Sodium chloride transporter. While loop diuretic mechanism of action is inhibition of sodium potassium 2-chlorine transporter. Carbonic anhydrase is blocking of carbonic anhydrase enzyme. Osmotic diuresis is due to this one creation of osmotic gradient. Thiazide mechanism of action is inhibition of sodium chloride transporter. You have to remember that. And the side effects are hyperuricemia, hyperglycemia, hyperlipidemia, and impotence. Okay, very important one is these four. Apart from that, sulfonamide hypersensitivity you may see. Sulfonamide hypersensitivity you may see. Then drugs act on the late DCT, which is your potassium sparing diuretics, which is of sodium channel blockers or aldosterone receptor blockers. Sodium channel blockers are amiloride and triamterene, and aldosterone blockers are your spironolactone and eplerenone are the two things where you may use it there. So spironolactone, drug of choice for hyperaldosteronic state, and it is also used for congestive cardiac failure. Amiloride, lithium-induced diabetes insipidus, very important. And you know, potassium sparing is the one which can able to produce a hyperkalemia, As I said in the class, remember one thing: whenever you see any renal failure patient who is on diuretic or any congestive cardiac patient who is on diuretic, immediately turn the page into potassium to check his potassium level, because most of the diuretics, except the osmotic and the potassium sparing one, most of the diuretics will produce hypokalemia. One of the commonest complications the patient may experience with the diuretic abuse is your hypokalemia. Okay, so for that, if the patient is coming to you with a hypokalemia, treat his potassium and try to change the loop or the DCT to potassium sparing one, but monitor it is having any sort of trouble with the patient. For example, it can complicate the metabolic acidosis, which is produced by your renal tubular acidosis patients. Okay, which can complicate the acidosis. So you have to monitor whether this drug is working or not. Okay, so then you can initiate the potassium sparing diuretic. But what is the thing you have to remember for your entire lifetime? Whenever you see the diuretic patient who is on loop diuretics or DCT or any diuretic except the mannitol and your, like a spironolactone or eplerenone or amiloride or triamterene, immediately check his potassium levels. Why potassium is important? Because it can create arrhythmias. Correcting a potassium is one of the very important source, so that it can able to, produce an arrhythmia. You can avoid that thing. Okay, entirely you can avoid episode of arrhythmia if you are managing the diuretics and your potassium effectively. Okay, you have to know that, people. You have to know that. Clear about that? So far we have done the diuretics. And apart from that, what are the antihypertensives which are safe in pregnancy? I used to remember with the mnemonic of Cynthia and Catherine Casser, pregnant mom. Cynthia and Catherine Casser, pregnant mom, which is a cardioselective beta blockers, clonidine, CCBs, hydralazine, prazosin, and methyl dopa. Okay, so this is a JNC and a textbook drug of choice, which is not asking nowadays, so that's why I am neglecting it. Okay, but remember one thing: what is the hypertensive safe in pregnancy? This is important. Cynthia and Catherine Casser, pregnant mom. Cardioselective beta blockers, clonidine and CCBs, and apart from that, hydralazine, prazosin, and methyl dopa. Okay, these are the things you have to remember, that these are the antihypertensives which are safe in pregnancy. Okay, for congestive cardiac failure also, we give a similar drugs. Congestive cardiac failure also, we give a similar drugs. And apart from that, you may have this apart from that, you may have this, nothing specific. All the most of the important things in the cardiovascular system has been discussed. Diuretics has been discussed, and ANS and the CNS has been discussed. So far we have done for the today's session, and tomorrow we will do autocoids and lower part and antimicrobial for 1 hour, and then we do the PSM part 1 for tomorrow. While day after tomorrow will be the PSM part 2. Okay, PSM is very exclusive because PSM have a vast content. We have a lot of hours to cover the PSM. That's why I split into part 1 and 2. Okay, so you may get at least 3 hours to cover the PSM. Okay, so far we have done the pharmacology part 1, where we have completed general pharma, ANS, CNS, and CVS, and diuretics we have covered. Okay, tomorrow we will do the remaining portion. So have a nice day, and see you all people tomorrow, and we will discuss the remaining portion tomorrow. Okay, take care, people.